truly questioning them, or sometimes understanding what the literature was behind them. So today we're going to discuss some of that literature behind some of these decisions and see if there's a better way we should be doing some of these things, or if we should keep on doing what we're doing already. So we're going to look at, before the incision, we're going to look at tourniquet use in surgery, review our options for preoperative skin prep. Now, intra-op section, we're going to review the literature on the skin knife as a potential source of infection, the examination of glove use in the orthopedic OR, and the evaluation of the suction tip in the orthopedic OR as a potential silent carrier of infection. And then finally, after we close our incision, we're going to be looking at our dressing options and practices. So tourniquets. Some of the earliest tourniquet use dated back to the Roman times. It was a device that they used to help control blood loss, especially in amputations. They're mostly bronze. The pneumatic tourniquet that we are familiar with was actually introduced in the early 1900s. The aims of the tourniquet use is to achieve a near bloodless field and to limit blood loss. It allows the surgeon to operate easily and more precisely and have good view of anatomic structures and potentially decreases operative time and overall blood loss. Some general considerations from Sharma that once we decide to use the tourniquet, there are a quick series of decisions that are often made with little thought. The first consideration is often out of our hands in that we don't have a choice as to the width of the cuff. But in rare cases, we do, and a wider cuff has been shown to require less pressure and is to be less painful. Our first real decision is what size cuff to use. Arm often gets the smallest cuff size, and then we generally make an educated guess as for the leg. But there are official recommendations that cuffs should overlap between 3 and 6 inches. Any more, and it can lead to increased complications due to high pressures. And hopefully we've thought about this before deciding to use the tourniquet, but there are some relative contraindications and considerations, including DVT, which in the setting of tourniquet use has been shown to lead to PE, severe limb infection, poor cardiac output, and peripheral vascular disease. Sickle cell disease is not a true contraindication. However, they can have an elevated complication rate up to 12% in a review of 4 studies by Sharma. So it is something to consider before you use it in a sickle cell patient. So after we decide to use a tourniquet, and if we have a tourniquet big enough to fit around the extremity we're operating on, the tourniquet is most often placed with the proximal humerus or proximal thigh. This provides the largest possible surgical field, provides a relatively safe and reliable use. However, they can be placed in many other locations: forearm, calf, ankle, depending on the location of the surgery. More distal tourniquets require less inflation pressure and may be better tolerated by patients. However, they do limit the surgical field and the ability to extend it proximally. Some of the research on how upper versus forearm tourniquets are tolerated comes from Odinson, who somewhat tortured his study subjects. 24 healthy volunteers had one cuff placed on their upper arm, and on the contralateral arm, or contralateral forearm, another cuff. To control for some bias, the study was randomized as to which arm got which cuff. The cuffs were then inflated simultaneously. The endpoint of the test was when the subjects could no longer take it anymore and requested the cuff was deflated. They recorded the difference of how long it took subjects to ask for deflation in each location. And under the conditions of the study, forearm tourniquets were tolerated for a mean of 7 minutes longer in the forearm than the upper arm. He suggested that patients undergoing hand surgery under local anesthesia only, 7 minutes may be a clinically relevant length of time. So after we decided where to place the tourniquet, next consideration often is if we're going to place padding under it. There's equal number of studies that argue for and against padding under the tourniquet. In the pro-padding camp, the argument is that the padding may decrease shear stresses from the tourniquet on the skin and may decrease skin trauma, particularly in the elderly. Olive Krona and Din both published small studies, randomized total knee replacement patients who were randomized to no padding versus padding. Both found around 23 to 24% of cases resulted in some sort of skin injury, and that the skin injury was significantly lower when padding was used. but maybe we don't need it. In contrast, to the papers presented in the previous slide, Bozeman and Robinson evaluated 97 patients with lower extremity tourniquet use and had 0 complications. They point to a study of over 63,000 cases in Norway, where only 3 cases of skin blistering were reported. Krona, in their own paper in the previous slide, reported that none of the skin injuries needed any intervention and were not present by 6 weeks post-op. So while skin blistering and abrasions certainly can happen with tourniquet use, and that padding under the tourniquet may decrease its prevalence, it is an uncommon event that often doesn't require any sort of intervention. However, the use of cast padding isn't completely benign either. There are cases in the literature where cast padding has become soaked with skin prep and stays under the skin under pressure of the tourniquet, leading to severe chemical burns. The recommendation is that an occlusive drape be applied around the distal end of the tourniquet to prevent the skin prep from soaking under it. In this particular case report, a 39-year-old male undergoing an ACL reconstruction sustained a full thickness near circumferential burn around his upper thigh at the site of the tourniquet after it became soaked with povidone iodine. There is some question whether it is a little bit less important for chlorhexidine-based preparatory solutions, as there's no case reports or literature on chlorhexidine-based burns, but the recommendation still stands to use an occlusive drape. So what pressure? There's no consensus regarding optimum pressures in tourniquets. The literature is unclear, and it may be why most surgeons choose to use a set pressure, often around 250 millimeters of mercury in most cases, with certain modifications. Obesity may choosing to increase pressure, children may choose to decrease pressure. Others advocate for using a set pressure above the systolic pressure, usually anywhere between 50 and 100 millimeters of mercury. There are several sets of actual formulas to use that are quite bulky. And so Levy et al. Created a simple formula based not on systolic pressures, but the MAPs, where tourniquet pressure was equal to 1.68 times the MAP plus 50. This formula was derived from arterial Doppler signals plus a 50 millimeter buffer for safety. Their calculations on subsequent 20 patients yielded tourniquet pressures significantly lower than we stand to use, just around 200 millimeters of mercury. One of the most cited papers on comprehensive tourniquet use, as well as tourniquet pressures, was published by Odinson, the same guy who was placing bilateral tourniquets on his volunteers. In this case, he surveyed all Norwegian orthopedic surgeons. About 2/3 of them responded. They collected over data on 63,000 operations at 71 institutions. In relation to pressures, a little less than half of the surgeons surveyed stated they used fixed pressures depending on location. The rest used approximately 100 millimeters of mercury above systolic. If we look at table 2 in the middle of the left side of the screen, we see that common inflation pressures in the study were anywhere from 250 to 300 millimeters of mercury, aren't consistent with our common practices at this institution. In addition to pressure and time, Odinson also reviewed complications. Complications were more likely to occur with higher pressures, over 300 millimeters of mercury, and tourniquet times exceeding 120 minutes, which is a widely accepted maximum time. Specifically, in one of the 2 permanent nerve injuries reported, there was a tourniquet time of over 120 minutes at 300 millimeters of mercury. So just some maximums that we should watch out for. But of course, setting tourniquet pressures to a measured systolic blood pressure uses a single data point, but blood pressure does not stay constant and often varies throughout cases. Most tourniquets are fixed, and any adjustment needs to be made manually. 2 studies out of Japan, one in foot and ankle and one in hand surgery, reported on a system where the tourniquet machine is set not to a fixed pressure, but for a fixed amount over the systolic. The blood pressure machine and the tourniquet machine actually share data every 2 minutes, so the tourniquet pressure is automatically regulated by the machine whenever it takes the blood pressure measurement. Both studies showed that a lower mean tourniquet pressure than traditionally recommended, just around 200 millimeters of mercury, or slightly less for upper extremity surgery, and were deemed to have clean, clear surgical fields. So just as a viable alternative if we want to get fancy. So now we've evaluated our tourniquet use. We're ready to proceed with our case. We've placed our tourniquet. Next, we decided what skin prep to use. So the earliest records of skin prep or skin aseptic solutions date back to Mesopotamia, where they used beer, oil, and wine. It wasn't until the 1860s with Lister that more modern skin aseptic solutions began. And when it was combined with von Bergmann's ideas in steam sterilization in the 1880s, we get the first sterile hospitals and sterile ORs, as well as significant reduction in infections. So there are three common skin aseptic solutions that we use. Alcohol being the first. It's also probably the oldest one. It's still used in many surgical preps today. It provides the most rapid action and reduction in bacterial count of any aseptic solution. It also tends to have a very short duration compared to both chlorhexidine and iodine. And thus it is often combined with these other aseptic agents. Additionally, while alcohol does have broad spectrum activity, is very poorly sporicidal. And our one major concern is that alcohol combined aseptics are highly flammable, requiring drying in the OR before progression to surgery, especially with electrocautery use. Iodine is the next one. It was initially recognized as a skin aseptic solution back in the 19th century. However, due to skin toxicity, it wasn't until less toxic compounds were discovered in the 1950s. Povidone iodine has broad spectrum of antibacterial activity, with activity against both gram-negative, gram-positive bacteria, fungi, protozoa, spores, and mycobacteria. It is a preferred agent in open wounds. Iodine is absorbed into the body at varying degrees and can interact with diagnostic tests of the thyroid and radioiodine diagnostics. It is actually listed as contraindicated in patients with hyperthyroid disease. The major downside of povidone iodine is that it is slow. You have to wait for it to dry. Finally, we get to chlorhexidine, or its water-soluble form, chlorhexidine gluconate. So one of the most commonly used surgical site aseptic solutions. It is broad antibacterial action against gram-positives and negatives, as well as fungi. However, it does not have any action against spores. It can have both bactericidal and bacteriostatic effects depending on its concentration. It's often used in combination with alcohol, and it can last on the skin for up to 48 hours. So which one is better? There's actually little consensus on this. While there's several good studies suggesting that chlorhexidine is superior, there are equally as many suggesting that there is no difference at all. However, I did not find any research suggesting that povidone iodine was superior. And one of the primary studies citing chlorhexidine is superior is from the general surgery literature published in the New England Journal of Medicine 2010. In this case, surgical site infections in general surgery cases were markedly reduced in patients who had chlorhexidine and alcohol sepsis compared to povidone iodine scrub. Interestingly, they do not note whether the povidone iodine was used in conjunction with alcohol in this case. So in a meta-analysis published by Yamin and Harvey in 2013 of primarily level 1 evidence comparing alcohol-based chlorhexidine and alcohol-based povidone iodine, they showed that irrespective of technique, alcohol-based chlorhexidine was more effective at reducing positive cultures only in the nail folds. In comparing positive cultures from web spaces or elsewhere on the foot and body, there was absolutely no difference. So it may not matter if we choose chlorhexidine or povidone iodine as our skin aseptic solution, but what about using alcohol or scrub brushes to apply it? Again, the foot and ankle literature has several published papers. Keblish in 2016 JBJS evaluated povidone iodine as a prep in a randomized controlled trial for simulated surgery. Regardless of the prep technique, the nail fold was always the most heavily contaminated, with almost 80% of cultures positive in just povidone iodine alone. So not so great. Alcohol pre-wipes did not significantly improve this in the nail fold, but did improve it in the web spaces. Finally, with the exception of the nail folds and web spaces, two notoriously hard areas to clean, povidone iodine did extremely well. No growth in the area. And then to our most common procedure at our institution, the alcohol first, then chloroprep. Hunter, 2016, evaluated the order of prep. He randomized two groups, an isopropyl alcohol first, chlorhexidine second, or a chlorhexidine first, alcohol second. When they prepped with the alcohol first, followed by the chlorhexidine, there was a significant reduction in positive cultures when compared to the chlorhexidine first, alcohol second. So we actually have data to support our practices here. In efforts to eliminate any possible bacteria from hard to kill areas in the foot, some studies have shown some interesting methods. Two papers on the bag immersion technique show some promising results. Chang showed that immersing a foot in a bag containing chlorhexidine gluconate and alcohol was equivalent to chloroprep, whereas Dingelman took the alcohol pre-wipe to the extreme. He submerged subjects' left lower extremity below the knee in 70% alcohol and 10% isopropyl alcohol, over a liter of it, for 5 minutes. He followed this with standard painting with a chloroprep stick. The right side received just the standard painting. The left lower extremity had significantly reduced colony-forming units on cultures taken from the subungual area. Otherwise, the rest of the foot had no colony-forming units, regardless of technique. And they suggested that the bag immersion method was superior to standard painting methods. So I don't know if we want to go this far, but if we ever want to get those nail folds truly clean, we can submerge the guy's leg in alcohol. So I've just presented the last several slides, all from the foot and ankle literature on this topic, mainly because the foot and ankle has some notoriously hard areas to clean. The literature specific to this topic on other subspecialties is actually limited. In a 2019 review of skin asepsis published in the JAAOS, the literature from joint arthroplasty was called, quote unquote, relatively lacking. The authors pointed out that preoperative skin prep, often referenced in arthroplasty papers, is actually from general surgery literature, suggesting surgical site rates with chlorhexidine alcohol were lower compared to povidone iodine. Out of the neurosurgical spine literature, Gabriel published almost 7,000 7,000 patients at multiple centers, showing no difference between chlorhexidine and povidone iodine. And finally, the shoulder literature. There's a significant interest in skin prep targeting C. acnes. Two cited studies showed that topical benzoyl peroxide in the days before surgery can reduce positive C. acnes cultures, but neither study could show reduction in postoperative infections. Okay, now we're moving on. We've prepped our patient. Our patient is ready. They have the tourniquet on. Their extremity is prepped. It's time for some gloves. It's well established that surgical gloves become contaminated over the course of surgery. Bakari reported that gloved fingertips became contaminated in 52% of general surgery procedures, while Davis reported that in almost 30% of gloves used while draping total joints became contaminated. The questions we aim to address today in this section are when else did they become contaminated? How often should we change them? And what else can we do to prevent them from becoming contaminated in the first place? So who contaminates a glove is also equally important as when. So it's common practice for orthopedic surgeons to change gloves after draping, okay? But who needs to be changing them? In 2014, Mackay published the rates of contamination after prepping and draping in total joint cases. They are substratified by level of training, so residents or attendings, hips versus knee, dominant versus non-dominant hands. They found the contamination was more likely to occur among junior surgeons, in hip cases rather than knee cases, and on the dominant hand. However, no one group escaped contamination, and thus they recommended all surgeons of different grades replace their gloves used in draping to avoid exposing the patients to risk. In general, the contamination was found mostly on the thumb and index finger, and after changing gloves, they had no contamination on the new gloves. Finally, They showed there was no difference if the surgeon used a standard 2-glove technique and then replaced their top gloves only versus initially putting on 3 gloves and discarding the top gloves. Gloves don't just become contaminated during draping though. Baldamy evaluated 29 consecutive total hips with 4 key areas of glove changing for the entire surgical team. This included the surgeon, the assistants, and the scrub nurse or tech. They had a total of 769 gloves they cultured. Actually, 69 pairs of gloves. The 4 key areas were broken down into draping, incision and bone prep, implantation, and closing. 26 contaminated gloves came from all members of the surgical team, the operator, scrub nurse, and the assistant, with the main surgeon was contaminated most often 11 times, whereas the assistants and scrub nurses were contaminated slightly less frequently at 7 and 8 times. In contrast to the previous study, they did not find any difference in hand dominance. In this particular study, the joint reduction / closing stages contain the highest proportion of positive gloves, 38% of the positives. And when they analyzed this as the number of contaminations in relation to the total gloves used, the surgical stage accounted for just 6%. However, the rate of contamination during draping was very low at only 3%. And this is in contrast to previous literature citing anywhere from 20 to 40%. So the study on the previous slide also evaluated perforations in gloves at the same surgical stages. These perforations, again, appeared in all surgical stages, with surgical incision and bone prep stages, as well as cup and stem implantation stages, accounting for almost 80% of all perforations. The frequency of perforations was 3.5% in all gloves used in the series. And disassociating the cup and stem implantation stages into cup implantation and stem implantation, these guys were changing gloves very, very frequently. The surgeon changed gloves over 6 times during the case. They noted that the majority of perforations took place during the femoral implantation compared to the acetabular implantation at 5% versus 2%. Unsurprisingly, the surgeon's gloves are the most likely to show perforation, and unlike the contamination, perforations were most likely to be on the dominant hand. All of the perforations in this test went unnoticed. So perforations happen, but what can we do about them, and do they lead to infections? Orthopedics is actually an outlier compared to other surgical subspecialties or surgical specialties in the wide use of double gloving. We are considered to be at high risk of glove perforations due to the general nature of orthopedic surgery. The Cochrane review in 2006, gloving practices across 31 randomized controlled trials were evaluated. There is no evidence to determine the effect of wearing additional gloves in transferring infections. Double gloving does lead to fewer inner glove perforations compared to single gloves. The indicator glove only increases detection of perforations. It does not change the overall number of perforations. And finally, wearing a glove liner, so either a woven glove liner between your pairs of latex surgical gloves or on the outside, significantly reduces perforations when studied in joint replacement. However, wearing a steel outer glove does not change the number of perforations. I don't know who's wearing steel outer gloves, but so we know that the gloves will become contaminated. We know that they'll be punctured with and without our knowledge. So is there recommendations on how often we should be changing them? The current guidelines, Infectious Disease Society of America recommends changing gloves whenever perforations are noted. There's no detailed local or international guidelines regarding optimal timing and frequency of glove changing. However, a systematic review by Kim found 8 studies, including 2 randomized control trials evaluating contamination on surgical gloves. Both Maya and Ward studied contamination in randomized groups, or groups randomized to change versus standard practice, which would after draping and before implantation. They found significantly less contamination in the frequently changed groups. And based on these studies, Kim recommended gloves should be changed after draping, as standard, before handling any implant, and at least once per hour. So glove contamination doesn't just happen during the operating room case, but also happens during initial donning, as shown by Bird et al. Okay, in a study published out of Duke in 2019. Through the cuff, it will potentially transmit contamination to the outside of the gown through direct contact. Additionally, we've all seen glove cuffs turned down during surgery, leaving direct exposure to contaminated surfaces on the surgical field. Bird evaluated standard or preferred donning techniques to a new novel glove-gown-glove technique. They use staff-assisted sterile glove is placed on the hand first, then the gown, and then the standard donning technique for the top glove. In testing 37 sets of proposed glove first versus preferred technique, there was 0 cuff contamination in the glove group or glove first group, whereas the traditional donning groups, where the contamination was seen on average of 12 centimeters up the glove sleeve. So not an insignificant distance. They acknowledged it would be extremely difficult to power a study to show a decrease in the number of surgical site infections from this using this technique. And the study was relatively small, but should be considered an option as a potential to reduce source of infections. And this technique is actually used by one of their attendings at Robert Wood. And he's the only person I've ever seen it. All right, knife. It's common practice among surgeons of all specialties to discard the scalpel blade used for skin incisions and to use a fresh blade for deeper dissection. The thought being that although the skin surface is rendered sterile by scrubbing technique, as much as 20% of skin bacteria may remain in sweat glands and hair follicles. They are a potential source of wound flora that can be transferred to deeper tissues by the knife. In a study in 2008, 58% of all US orthopedists reported discarding the skin blade. But how much truth is behind this? And is it a practice we should be encouraging? So the practice of the skin knife versus deep knife may date back to the late 1800s in a series of papers by Welch, who argued that skin bacteria could be transferred to deep structures by the scalpel blade. However, by the 1970s and 80s, there were a series of papers published arguing that this is likely not a necessary practice, and that positive blade findings does not equal causation. Hill, in 1986, published a survey and study from the Royal College of Surgeons in England. All but one of the surveyed participants reported changing the blade from skin to deep blades. However, when they evaluated 93 sets of blades from a mixture of orthopedic, general, and OB-GYN surgeries, they found 22 positive cultures with a mix of normal skin flora, mainly staph epidermidis. And from this group, only one patient was found to have a surgical site infection, and the bacteria did not match in this case. The infection was from in a bowel case that was positive for E. coli, not staph. Fast forward to January 2001. JAOS, we are still discussing this. In this case, Smith argued that other studies that were proponents to the deep versus skin knife, showing that skin scalpels had a potential source of contamination, the control blade was opened and immediately cultured. He suggested that a more appropriate control blade is one that is exposed to the same OR for the same length of time as the incisional blade, thus removing any potential confounding contamination through the general operating room environment. He found positive blades in 35 of almost 700 specimens, with no difference in the rate of contamination of positive cultures for the skin blade at 17 versus the control blade just sitting on the operating table at 18. Additionally, there was no difference in observed rate in positive cultures depending on the type of case, either total joint or spine cases. And he concluded that although efforts should never cease in fighting to reduce contamination and eliminate surgical site infections, it seems that changing the knife blade after making skin incision is not an effective way to reduce contamination. However, luckily, knife blades are very inexpensive. As he pointed out, At their institution, they cost about 25 cents. So they also suggested that knife blades should be discarded at the discretion of the surgeon for any reason. However, contamination really isn't one of them. That being said, Levy came to a different conclusion in the shoulder literature in regards to C. acnes. C. acnes is demonstrated to be the most common microbe identified in patients with prosthetic joint shoulders infections, and is very difficult to eradicate. In a pilot program, which had initially been planned for many more subjects, but was halted due to COVID-19 and stopped at only 17, the skin knife was swabbed for cultures that were taken directly to the microbiology lab and held for 21 days. The skin knife cultures from two patients of the 17, so 11%, grew C. acnes. They concluded while they had no post-op infections, 11% is a high proportion of contamination, and the low cost of changing blades may justify their change. So even though the paper from 2 slides ago would argue that you don't need to worry about changing blades at all, one of the common practices is to use iodine impregnated drapes or iobands. So do these drapes actually prevent contamination, skin contamination onto the blades? The answer is probably yes, but it's likely, but like many of these studies, it's very hard to prove contamination leads to surgical site infection. Scheit in 2020 published in the journal Orthopaedic on blade cultures taken with and without ioband drapes. Contamination of the blades was significantly less at 3.8% versus 12.2% without. All right, moving on. Suction. Finally, the intra-op section for this presentation, the humble suction tip, which may be the most overlooked of the possible sources of infection during the case. The use of suction system is routinely used in orthopedic surgery. We use it to clear debris, suck surgical smoke and blood. The system is constantly operating, aspirating large quantities of blood, fluids, and air. The continual passage of large quantities of air through the blood-soaked catheter tip has been postulated to lead to contamination, which in turn has been linked to theoretical risk of deep wound infections. Javices in 2018 cultured suction tips at the end of 50 consecutive cases. 27 out of the 50 cases, 54%, were found to be contaminated with at least one bacterium, and 4 cases grew up more than one bacteria. In subgroup analysis, only 1 of 11 cases under an hour had a contaminated suction tip. They're contaminated for both, so staph species accounted for 21 of the 27 positive cases and were present in all of the suction tips that were contaminated with more than one organism. Finally, all the cases were followed out to 12 months for any post-op infection. There was 1 case recorded with a microorganism responsible for the infection being the same one that had been cultured from the suction tip in that case. So multiple studies have shown the risk of contamination of surgical suction tip increases with the length of time of surgery. I know we rarely ever change our suction tip. However, Brine showed a contamination rate of 17% in surgical procedures shorter than 90 minutes and 33% in those longer than 90 minutes. Whereas Gonzalez noted possibility of suction tip colonization doubled after 60 minutes in surgery and was 8 times higher after 90 minutes of surgery. Similar to contamination found on surgical scalpels, staph species are the most common. So the recommendation is actually that suction tips be replaced every 30 minutes, and that, like we do at Robert Wood Johnson, the suction tip not be used to collect irrigation fluids on in the reservoirs or on drapes. So that's not the right case. That's the right case. So yeah, out of the 546 suction catheters that were analyzed in a trauma room, 7.3 were found to be positive for pathogens. Staph epidermis was isolated about 27% of the time. So one of the most common practices at Robert Wood Johnson, specifically the ortho trauma room, is to not use the suction tip for the effluent after irrigation. I was unable to find a study that directly evaluated this practice. However, it's possible this practice may be an extrapolation from studies showing irrigation fluid and wash basins are common sources of contamination during surgery. 2018, Fuchs evaluated residual and accumulated irrigation fluid from the surgical drapes in 100 cases of total knee recipients. They had no positive cultures at 30 minutes. However, at 60 minutes, 22% of the samples taken from the drapes were contaminated. That increased to 23% at the end of surgery. Again, it's a total knee, so the cases aren't lasting much after an hour. This was directly correlated with the suction tip, which was contaminated 22% of the time at the end of the case. They recommended that the suction tip be replaced every 30 minutes, and that, like we do at Robert Wood Johnson, the suction tip not be used to collect irrigation fluid from the reservoir or from the drapes. Finally, we get to splash basins. These aren't something that we regularly use as residents or surgeons. However, if you look at the back table, they do regularly get used in orthopedic cases. Splash basins have been used for many years in the OR. It's a place to wash instruments and clean them from debris for potential reuse during surgical cases. Often you get multiple instruments in there at one time in direct contact with another. And despite their common use, many studies have shown bacterial contamination in these basins ranging anywhere from 2 to 74% of the time. They are cited as an opportunity for bacteria to be transferred from one surgical instrument to another and to the wounds. And the most recent consensus statement by the Musculoskeletal Infection Society recommends against the use of splash basins. However, in direct contradiction, the Association of Surgical Technologists and the Association of Perioperative Nurses recommend their use. So at Robert Wood Johnson, these basins are routinely used. I've noted these basins being at the end of cases, the scrub nurse or scrub tech suctioning these basins out with our suction tip, sometimes before we're totally finished with the cases, or being handed up when somebody asks for the big basin for irrigation. So just be careful, don't put the suction tip in there. They're often contaminated. All right, so now we've successfully completed our case. We've managed to avoid any pitfalls or significant contaminations of our gloves or suction tips. We replaced our scalpel, but it was because it was dull and not because it was used on the skin. So how are we going to protect our surgery and our surgical site from the outside world after the OR? Dressings. Dressings generally fall into three main categories on the basis of function. Passive dressings cover the injury site, physically protect the wound, and help control exudates. However, their capacity is limited, requiring frequent evaluations and replacements. The next category is active dressings, which promote healing through a moist environment and are less likely to become adherent to the injury site. And finally, we have interactive dressings, which supplement the mechanisms taking place in one or more of the wound healing stages. So there's a wide range of dressings commonly used in orthopedics. They range from the very cheap with a gauze 4x4 costing around 15 cents, all the way up to the extremely expensive with a Provena incisional vac, potentially costing over $1,000 per dressing. Starting with the most common dressing in the world, gauze. It's either woven, which is 100% cotton cloth, or non-woven, which is usually a rayon synthetic fiber. It falls into the passive dressing category. It provides no antimicrobial defense on its own and does not interact with the wound. Ubinic evaluated gauze versus occlusive dressings for wound care. They found there was no difference in overall wound healing. It actually took a few days fewer for wounds to heal with gauze compared to the occlusive dressings. The drawbacks of the gauze dressings is that they usually have to be changed more often, and they can stick to wounds, leading to local trauma when they're removed. However, they're incredibly inexpensive, and as I referenced in the last slide, it costs about 15 cents per dressing. Gauze dressings are often combined with semi-permeable dressings, such as tegaderms or opsites. These fall into the more active dressing category. They allow gas passage and water exchange while being waterproof. These dressings can have absorbent materials built into them, or they can be combined with other passive dressings. They tend to be flexible, they're easy to apply, and they create a barrier in many cases, like I said, are waterproof. The drawback is on their own, they're not very absorbent, and they tend to be a little bit more expensive than the humble gauze dressing. Next, we have hydrocolloid dressings, such as aquacell dressings. They're made of 2 layers. It's another, and this is another example of an active dressing. The inner layer is larger. It's usually made of a gelatin, elastomers, or some sort of pectin, and an outer layer that is impermeable to water or vapor. The major advantage of these types of dressings is that the inner layer can oftentimes hold 30 times their weight in fluid, and they're ideal for wounds that produce large amounts of exudates. And while they're marketed as being waterproof to allow showering and bathing, Tegaderm dressings have actually been found to be more waterproof. The major disadvantage is that they're more expensive. Finally, the last category of dressings is antimicrobial dressings. They're an interactive dressing. They can be made from several different materials, with silver impregnated dressings being the most common. Tisosky published small studies of 50 patients undergoing total knee arthroplasty that were dressed with either a silver nylon dressing or standard zero-form gauze dressings. The silver dressings were replaced only if saturated and finally removed on post-op day 7, while the standard dressing was changed on post-op day 2 and anytime it was soiled, which was usually about once a day in the first few days, and then ultimately discontinued when the wound was dry. The results showed that silver nylon dressings had decreased PJIs and decreased stitch abscesses compared to the standard dressings. However, these dressings are much more expensive. So Tisosky is directly in contrast with a recent meta-analysis in the Cochrane Review 2016. They had 29 randomized controlled trials of different types of dressings, including everything from antimicrobial dressings to passive wound coverings. The authors concluded that it's uncertain whether any particular dressing is more effective than any other dressing at reducing surgical site infection, improving scarring, reducing pain, improving acceptability to patients, or is easier to put on or remove. They actually suggested that surgeons may want to make the decision just based on cost and what the patients prefer. However, there was an extremely high level of bias reported, indicating the studies were small and conducted by centers already reporting a very low level of surgical site infection, making it difficult to draw conclusions. So it may not really matter what we put over our wounds, but how long do we keep it covered? 1977 in Nigeria, Ajao published a comparison of dressed versus undressed surgical wounds. The conventional method at their hospital of surgical wounds was using a relatively watertight cotton gauze and elastoplast dressing. This was left in place for 7 to 10 days, unless there was evidence of wound infection. They randomly assigned 100 patients into 2 groups. One where they kept their normal standard practice, and the other where after 24 to 36 hours, dressing the wound was left open to air. They found no difference in the rate of infection. This previous study is corroborated by Toon, who published a meta-analysis in the Cochrane Review 2015 on delayed versus early dressing removal for surgical patients with clean or clean contaminated surgical wounds. In 3 trials were included, and like the previous meta-analysis, all trials were evaluated to have high risk of bias, but overall 280 people were included and randomized and had been randomized to early dressing removal, so within 48 hours, or delayed dressing removal beyond 48 hours. There was no statistical difference between the early dressing group and the delayed dressing removal group. A proportion of people developed surgical site infections, superficial wound dehiscence, and serious adverse wound events at 30 days. There are no deep wound infections and no deep wound dehiscence in any of the participants. They did not comment, however, on number of phone calls the patients or the attendings received over concerns about their wounds. Finally, among the most common questions when speaking to operative patients is, when can I shower? The answer tends to depend on specific protocols of the attending surgeon. However, what does the literature say? Again, we go back to systematic reviews. So published in 2013 of over 2,000 patients, 76% were allowed to shower and bathe before the sutures were removed. This ranged from immediately to post-op day 5. They compared it to 295 patients who were restricted until suture removal, generally around 10 to 14 days, and 216 patients who were restricted getting the wound wet, but had no defined period of time. These 9 studies were across surgical specialties, including spine, foot and ankle, peds, neurosurgery, and general surgery, and showed that showering or bathing had no bearing on the rate of post-op infections. And they suggested that patients can return to showering and normal bathing as soon as 12 hours after surgery without the risk of surgical site infection. All right, so conclusions, recommendations. So going back to our beginning of our case, the tourniquet, we should use a wide cuff that overlaps by no more than 6 inches. The longer the time that is inflated and the higher the pressures have an increased risk of complications, and 100 millimeters of mercury over systolic blood pressure is adequate. However, pressures above 250 millimeters of mercury is likely not needed. Skin prep, chlorhexidine may be superior to povidone iodine. However, both are very effective as skin prep, and alcohol, if used, should be used prior to the other ones. All right, next we have the skin scalpel blades. They don't need to be changed due to concerns of contamination, but they're cheap, so change them for any other reason. Gloves. Gloves get contaminated, and the longer the case, the higher the risk. Gloves should be changed after draping, before touching any implant, and at least once per hour. And while double gloving does not prevent perforations, or sorry, double gloving does prevent perforations, indicator gloves help you detect them. Suction is the overlooked area of contamination, should be changed at least once an hour. And we shouldn't use the suction tip to suck from fluid basin or off the drapes, as they're also major sources of contamination. And finally, dressings. Probably doesn't matter which one we choose. Choose one that reduces phone calls and keeps the patient happy and comfortable. Dressings don't actually need to be covered for after 48 hours. And patients can shower as soon as 12 hours after the case. Without any risk of surgical site infections, you actually don't need a waterproof dressing for this. Here are my references. Open to any questions.
Andrew?
Yeah.
I don't know if anyone's talking in the audience, so my question is, the geniuses that decided that it was like critical for us to put suctions at the end of a bovie, do you think that has any implications, since we really don't, most of us don't use a knife for most of the case, just for the skin incision, and then we use the bovie for the entire rest of the dissection. So if you have the suction on at the end of the bovie for the whole case, how do you think that has it? You think that has any impact or implications? And did anybody ever look at it?
I did not specifically find anything that talked about suction tip on bovie. I think the one advantage of compared to normal suction tip, I think it could potentially be a source of infection. However, I think the one advantage is that they can show the amount of air flowing through the suction tip and contamination are directly correlated. So the longer and higher you have the suction, the higher the risk of contamination. The bovie suction tips only actually turn on when you're using the bovie, and they're otherwise are off. So potentially, and it's not quite as strong of a suction, potentially would have a decreased risk compared to the normal suction. But again, you are sucking air and fluid and smoke and potential for contamination right next to where you're cutting. So you could potentially contaminate your field with that. Like I said, I didn't find anything specifically on that. It'd be interesting to look at that though, whether there was any contamination. We do that study here. Yeah. Swabbed our suction bovies. Joe Mark's volunteering. Joe Mark asked me if I'm going to start doing gown glove. I think it's interesting. It was obviously, they used a lotion that was fluorescent as a indicator of possible contamination. So it possibly overemphasized where contamination was. We scrub our hands. It is good, it is a good preparation. It's not like our hands are completely dirty, but it does show that there's 12 centimeters up your sleeve is not insignificant. So I've tried it once when I was working with Dr. Kairos, who does it. Maybe I'll go back to it now that I actually read the study. The hardest part is getting the scrub nurse or scrub tech to do it. Yeah. Thank you very much.